Soulen. He is from University of Pennsylvania, USA, and he's going to give us a talk on colorectal cancer, integration of intervention oncology in the care plan.
Thank you. So I was asked to speak about treatment in metastases. So I'm actually going to give two lectures back to back because what I wanted to do was divide them by disease state. You know, as interventional oncologists, you're really an oncologist. You're a cancer doctor. You're not just an interventional radiologist who does procedures. And we always treat patients in the context of the disease that they have. So we want to conceptualize them that way. So we're going to talk first about the approach to colorectal metastases. In the next lecture, we'll have the same conversation, but about neuroendocrine tumors. So if you meet a patient who has metastatic colon cancer to the liver, really they have a few options. One is, of course, to do nothing because they have a fatal disease, most of them. And if they choose to do nothing, their survival on average is 7 or 8 months with no therapy at all. On the other side of the spectrum, you could try to cure them. To cure them, they have to be resected. And if you resect them, you could have 5-year survival of up to 40%, which is considered the equivalent of a cure in metastatic colon cancer. And most people end up somewhere in between, and the standard of care would be systemic therapy, which will extend their median survival to between 1.5 years and 2 years, especially if they have liver-only disease. So most people go that route, and that is considered the standard of care. So if you look at the treatment guidelines, both the NCCN in the US and ESMO in Europe, they basically say the same thing. And you should really know these, because if you're going to be treating patients with metastatic colon cancer, you're going to be interacting with the medical oncologists as well as the surgeons and radiation therapists, and you have to be able to speak their language. So if you're going to go to a tumor board or you're going to interact with a colleague in medical oncology about the management of a colon cancer patient, you have to know what it is that they do. You have to be able to talk the talk. You have to be able to advise your patients. When a patient comes to see you, you're not just going to talk to them about ablation or just talk to them about embolization, but you're going to put that in the context of systemic options. And you also have to understand, if they're on systemic therapy, what the implications are for treatments that you want to do. So first-line therapy is a triplet therapy, either FOLFOX or FOLFIRI, which is 5-FU-leucovorin, either oxaliplatin or irinotecan. They can start with either one, doesn't matter which one. They often will get Avastin, a VEGF antibody, bevacizumab. And then if they have wild type for the KRAS or BRAF genotypes, then they also benefit from being on an epidermal growth factor receptor inhibitor, EGFR inhibitor, which could be Vectibix or Erbitux. So some combination of those is going to be what most patients get, and most likely they'll already have had it by the time they get to see you, most of the time. Once they progress on that, then they get the other triplet combination. So whichever of the 3 chemotherapy drugs they didn't get, they'll switch to the other one. And then again, they may continue Avastin or they may continue on an EGFR inhibitor. So since that's what most patients are going to get up front, you should understand what the benefit of those are. So it turns out that many of them respond. So the response rate is actually quite high, 40-60% in response. I mean an objective response, so at least a 30% reduction, a PR or a CR. About a quarter of them will actually get downstage with chemotherapy alone to being resectable. And if you resect them, the 5-year survival is about 33%, pretty good. So that may be all they need, is just chemotherapy, downstaging, and resection. Now, most people won't get downstage, so for those patients, the median time to progression on first-line therapy is 7 to 9 months. They switch to second-line therapy. That will get them another few months. They don't do quite as well. But if you then look at their overall survival, assuming they don't go to resection, in aggregate, it's somewhere around the 18 to 21-month range. So that's standard of care. That's what all the guidelines say. That's how medical oncologists think. That's what your patients will be getting. So since they're going to be on these drugs, you have to understand what these drugs do to them before you do something to them. So oxaliplatin causes a peripheral neuropathy, a very classic finding, and the most disabling therapy. So in fact, many people stop FOLFOX not because it's not working on their cancer, but because they get a progressive neuropathy and they have to stop it. It also causes venostasis in the liver, veno-occlusive disease. So they get a blue liver, a very congested liver, and it causes various cytopenias. Irinotecan, the active drug in FOLFIRI, causes diarrhea. It causes steatohepatitis. They get a yellow liver, and they also get bone marrow suppression. The 5-FU gives them mucositis and diarrhea. If they're on cetuximab, Erbitux, they get this classic rash. Many of the patients do. So when the patient walks in, they have this bright red rash all over their face and shoulders and neck. You could say, oh, you're on Erbitux, and they'll think you're a really good cancer doctor because you know what drug they're on. If they're on bevacizumab, Avastin, that has all sorts of complications. Proteinuria, they have delayed wound healing, they get GI bleeds, they spontaneously perforate their bowel, and that can be an issue, especially if you're going to do procedures on them. Any combination of chemotherapy for more than 6 months gives you chemotherapy-associated steatohepatitis, so those livers, even though they look normal, are not. They're significantly diseased below subclinically if they've been on chemotherapy for more than 6 months. And the implication for that is they're not as resilient. So if you want to do a downstaging to resection, instead of needing 25% of their liver left, you're going to need 40% of their liver left before you can resect someone after more than 6 months of chemotherapy. So that's one important thing to understand in their history. And then Avastin, although it probably doesn't really affect your ability to catheterize the patients in terms of complications, if you're going to do surgery like putting in a chest port, they need to be off Avastin for a few weeks, so they'll have wound dehiscence. So this is kind of the approach that I think of when I see a patient with colorectal liver metastases. When I see one, the first thing I say is, are you resectable? Because it's amazing how many patients show up from a community hospital, and you look at their CAT scan, and they could be cured by resection, but no one ever told them that. So I look at the CAT scan, if I say, I know where to draw a line in the middle of hepatic vein, so I'm not a surgeon, but I can say, you're probably resectable. Why don't you go down the hall and see my surgeon first? And if he says no, come back. So if they're resectable, usually they get a few months of chemotherapy, just as a little test of time, get some cytoreduction, make sure they're not going to have a lot of other mets. Maybe the surgeon will want a portal vein embolization if the left lobe's a little small, or maybe if they're sort of marginally resectable, we'll downstage them with an embolization first. But generally, that's the route we take. If they have widely disseminated disease, then they go on systemic therapy. And if they're in this middle group, the liver dominant but not resectable, and they have adequate labs and adequate performance status, then we're going to do image-guided therapy. And we might, if they're small, we'll ablate them. That doesn't happen very often in colorectal cancer. Less than 10% of patients present with 100% ablatable disease. If they're intermediate size, I might do a combination of embolization and ablation. And if they're large or multifocal, we'll just do some form of embolotherapy. But that doesn't replace their systemic therapy. Often they'll continue on their systemic therapy if they haven't exhausted it all already. So that's the path we would like to take. Unfortunately, that's not what happens most of the time. Usually what happens is they go to the medical oncologist, who gives them first-line therapy until they progress. Then he gives them second-line therapy until they progress. And then when he's done and has nothing else to offer, then he calls you. All right, so you're getting advanced, late-stage patients with declining performance status, and you're now in a salvage situation. And what you really want is this. You want, while they're seeing the medical oncologist, for them to come to see you also if they have liver-dominant disease, so you can add value by offering therapy as an integrated plan with your medical oncologist. And if you look at barriers to access to interventional oncology therapies, one of the largest barriers is that the medical oncologists don't know what we do, or if they know what we do, they don't know anyone who does it. So they don't know who to send a patient to. So building those bridges with your medical oncologist, best done through tumor boards, is the key first step in overcoming that barrier. So here's a case. Patient showed up in my clinic. 2 10-centimeter metastases. You can see the coronal CT, and you can see the PET scans. So 2 huge metastases taking up most of the liver. All right? So what would you do with someone like this? Chemotherapy? Well, that's the standard of care, right? I mean, everyone would do chemotherapy as the first thing because that's what all the guidelines tell us. But would you try to resect them? Would you offer chemoembolization or radioembolization, or would you offer portal vein embolization? So how many people would chemoembolize this patient? Not a lot. Some? No. How about Theraspheres or Therasphere? More. How many people just do a portal vein embolization? Good. Okay, so we see a wide range of possible choices in this guy. So the question, as I said at the beginning, when I look at a CAT scan, I think, are you resectable? And if you're not, can I make you resectable? Okay? So I'm sorry, these pictures are going to come up out of order because my animation got messed up. This is what it looked like after 3 months of chemotherapy and portal vein embolization. And this is what he looked like before. All right, so basically, here's this guy, 2 giant 10-centimeter metastases. You put him on standard of care chemotherapy, give him 3 months to respond. Now he has this little bit of a response, but his left lateral segment is clean, has no tumor in it. It's just too small. So we do portal vein embolization, not chemoembolization or embolization, grow his left side big enough, and then he gets resected for cure, potentially. Okay, so this is how I have to sort of think about the patient. And what I always say to people is, there's this tendency when you look at a CAT scan, a patient with metastatic disease, it's like Swiss cheese. Everyone looks at the holes. You have to look at the cheese. And the question is, do they have enough cheese? And if they have enough cheese, you can cure them. If you just look at the holes, that doesn't answer that question. So always look at the cheese. And the other thing is, if you could find a way to refer that patient to a surgical oncologist for a big, juicy trisegmentectomy, he'll send you 20 ablations. He'll love you, right? So you have a good relationship with a surgical oncologist where he views you as someone who doesn't just take patients, but you send him patients, then he'll send you patients too. Here's a more challenging case. So this guy presented 16 metastases in 7 out of 8 liver segments. All right, so mostly you would look at this guy and say, there's no way you're going to be cured. But 3 months after chemotherapy, he has this great response. So a lot of his lesions disappeared. He still has half a dozen or more, but you map them out and you say, all right, let's do a 2-stage hepatectomy. So you're going to go in, the surgeon's going to go in, and first he's going to clear the whole left lobe. So he's going to wedge out or ablate the lesions that are left in the left lobe, which is going to leave you with a functional liver remnant about yay big. Then, after he recovers from that and the surgeon confirms that you have a left lobe that's free of disease, although he didn't leave very much of it, you do a portal vein embolization, you grow that now disease-free left lobe, and then you do an extended right trisegmentectomy, and you take out the rest of the cancer and he's cured. All right, so this is a multi-stage chemo, surgery, portal vein embolization, surgery, cure. Okay, by having an integrated team where the patient gets everything in the right sequence at the right time. So even someone who presents with a terribly dismal picture to start with, potentially by a group approach where you and the medical and surgical oncologists all work together, it doesn't always work out this way, but when it does, at least you give the guy a chance of being cured. Well, what about ablation? One of the arguments is, well, is ablation as good as surgery? And you can't really do a head-to-head trial of that. That's not realistic. But if you look at the outcomes of ablation by people who really know what they're doing and are really, really good at it, like Alice Gillham's in London, and you look at her 5-year survival treating ablation for cure, so A0 ablations, up to 5 lesions, up to 5 centimeters, 40% 5-year survival. And a little bit better than that if you treat smaller and fewer lesions. So basically, if you do if patients present with disease that's amenable to complete ablation, which for colorectal cancer is probably 10% or less of patients, but if they do, then between you and your surgeon, if you can get rid of all the disease, then your outcomes potentially can be as good as just surgical resection alone. So ablation, when it can be done, is a great tool to use in this disease. Now, most patients, 90%, won't be amenable to ablation. So you're stuck with the more typical forms of embolotherapy we do. So chemoembolization has been around for a long time. Chemoembolization looks very different in metastatic disease than it does in HCC. So you tend not to get this dense and uniform uptake of Lipiodol. So here you can see the top picture is pre-chemoembolization. There's 4 lesions here, 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 and in the caudate. After chemoembolization, you see that what you get is this peripheral ring-like uptake of Lipiodol with sort of central necrosis. All right, so you don't get this filling in pattern like with HCC. This lesion actually took out much more Lipiodol, the caudate not so much. But the important thing to realize is the second set of pictures in the bottom, that was 1 year later. Right? CA went from 200 to normal. She's asymptomatic, she's working full time. So probably this is a pathologic complete response, even though the tumors, a medical oncologist would call this stable disease, would call this no response, because the tumors didn't shrink. But in fact, they're probably dead, even though they didn't shrink very much on the CT scan. So if we look at trials of chemoembolization in metastatic colon cancer, there aren't a lot of them that have a significant number of patients, but this is more or less the last 10 years, with trials between 20 and Vogel's group in Frankfurt, over 500 patients. You can see a variety of different chemotherapies, fluoropyrimidine, cisplatin, the triple drug regimen we usually use in the US back when we had cisplatin, or Vogel, who used 4 different regimens over the years. Embolization, PVA, Lipiodol, degradable starch microspheres, combinations thereof. Disease control rate, so that means complete response, partial response, and stable disease, anywhere between 40 and 90%. Time progression, anywhere between 3 and 9 months. And of course, this is a mixed bag of patients. So some patients are salvaged, some are early in their course and are still getting chemotherapy as well. But it gives you a sense of how patients tend to do afterward. If we then look at survival, so same series, added one more that didn't have response data. Median survival from the time of chemoembolization, anywhere from 8 or 9 months here, 14, 21, 10 or 15, 16. So basically, better than you would expect with salvage chemotherapy. Remember, survival with salvage chemotherapy, once you get to the salvage stage, is only a few months. And here we're getting several months to more than a year. And here's sort of 1 and 2 year survivals with Chemolization, again, a variety of salvage and non-salvage cases. So this is the data from my place. This is the largest US series, about 120 patients. And this is survival from when they were diagnosed with their liver metastases. So whatever therapy they got, plus whatever therapy I did, and whatever they had after, median 27 months. So way better than what you'd expect with chemotherapy alone. Okay? And then this is the curve with confidence intervals going out over time. So that's when they were diagnosed with liver metastases. One of the things we looked at is, does it matter when you get them? And the answer is yes. So if we get them first or second line, or immediately for salvage after failure of second line, they do pretty well. But if you wait till they've had 3 to 5 lines of systemic therapy, they really don't do very well. We don't get that much more benefit. You're sort of exhausted. You're too far toward the end of the trajectory of their disease. So you do want to get them early, but even if you get them after they failed 2 lines, the standard systemic treatment now, if you get them right away for salvage, they do as well as if you got them earlier. Extrapack disease, someone asked a question about this earlier. In our experience, although patients with extrapack disease do a little worse, it wasn't statistically significantly different. And I think that's just because you have to be careful how much extrahepatic disease you allow. You have to look at the patient, you look at their CAT scan, you say, you have liver-dominant disease, I think you're going to die of liver failure. And so even though you have some adenopathy, or maybe you have a bone met or some small lung mets, they're not going to kill you. I always tell my patients, no one ever dies of adenopathy, right? You die from liver failure. So those patients, if you treat the liver, you expect to benefit them. So you can tolerate some amount of extrahepatic disease. Performance status, however, is huge. All right? So this compares people with a performance status of 0, asymptomatic, to anything worse than 0, even once. And you can see the survival is much worse if you have any symptoms from your disease. So that's a much more potent predictor of outcome than anything else. And then one of the things my medical oncologist asks is, we've made so many advances with chemotherapy over the last 20 years. Is chemolization helping anymore? And the answer is, if we looked at before irinotecan, before Avastin, or since Avastin with Avastin Erbitux, the biological era, you can see the survival has not changed in 20 years. From the 5-FU era to the irinotecan oxaliplatin era to the bevacizumab, cetuximab era, the benefit of chemolization hasn't changed. Whatever we do, it's still working. This is Vogel's data from Frankfurt, much larger series, 400 and some patients. This one graph shows both the survival from diagnosis and the survival from chemoembolization. You can see his is better than mine even, so over 3 years from diagnosis, median survival over a year from the time of chemoembolization. One thing that I will say is different is that he does not treat any extrahepatic disease. So this is all liver only, which probably is a better prognostic group. He also chemoembolizes much more often. He uses degradable starch microspheres, which last for 20 seconds and they disappear. And he goes back and does these people in a more scheduled fashion. So people often get 4 to 6 chemoembolizations, whereas I usually only average about 2. He looked at survival relative to whether they responded or not. And it turns out the patients who actually had a partial response, so a 30% reduction in tumor diameter, did marginally better than ones who had stable disease or progressive disease. Not surprising. He also looked at all his drug combinations, and it turns out, as in every other study, it doesn't matter. So no matter what drug or combination of drugs he used, exactly the same survival curve. So at least in his experience, drugs don't matter. What drug you use doesn't matter. What about drug-eluting microspheres for this? Most of the work's been done with irinotecan loaded onto LC or DC beads. There's a large registry, an international registry with centers from all over the world that's been published. It's the same 55 patients published in 3 different journals. But basically, they treated patients with 100 milligram doses of Debiri, usually 2 treatments, so a total of 200 milligrams entirely. Many were on systemic therapy as well. Their response rate, which was actually disease control, so stable disease or response at 12 months, was 75%, and their overall survival was a median of 19 months, which is pretty good. Progression-free survival about 11 months, sort of in the similar range to what we saw with conventional chemoembolization. But most interesting is this study that was just published about a year ago out of Italy, where they actually did a randomized trial. So they took patients who progressed on oxaliplatin therapy, and they randomized them to either just going on FOLFIRI, the standard second-line therapy, or they did 2 irinotecan microsphere treatments and then went on the FOLFIRI, same drug. And this is progression-free survival and overall survival. And you can see that the Debiri arm was better for progression and better for overall survival than the chemotherapy alone. So this is the only really prospective randomized trial for irinotecan-loaded beads in this disease, but again, suggesting that there's benefit sort of in a second-line setting. The other alternative is yttrium therapy. So there's Theraspheres and Cerspheres. In the US, We have labeling issues, so Therasphere has only a limited approval for primary liver cancer only and cannot be used for metastatic disease unless your IRB allows you to. Therasphere in the US has FDA approval as therapy for metastatic colorectal cancer, so it's fully labeled for that, which means you can, as a physician, you can use it for anything. Again, sort of limited data on this, but this is a phase 3 trial looking at protracted infusion 5-FU with or without Therasphere. So the 46 patients, they randomized them to infusional 5-FU, which is not the standard of care at all, very old-fashioned chemotherapy that you wouldn't do anymore, with or without Y90. And their primary endpoint was time to progression in the liver, and you can see there was a significant improvement. So 2 months on infusional 5-FU, up to 5.5 months for the patients who also got atrium renal embolization.
Dr. Michael, time is 2 more minutes.
Okay. And then if you look at the large series out of Australia, where Therasphere started, this is Bester's series. I forget how many, it was like 224 patients who got Therasphere therapy, and they compared them to 29 patients who were similar but didn't get therapy for some reason, just went off and got supportive care. And you can see, again, a big separation in survival between standard of care and people who got renal embolization. And then this is Andy Kennedy. This is it's like a 10-center trial, 600 patients that was presented at ASCO. They saw partial response rates of about 35%, disease control rates of about 90%, median survival about 9.5 months. So again, somewhat similar to chemoembolization, and really the responders did very well and people who didn't respond did quite poorly. So if you look at kind of where we fit in the equation, this is sort of a classic slide showing the gradual improvement in survival with chemotherapy over the years. It's going from just 5-FU back in 2000 up to FOLFOX, FOLFIRI, et cetera. And you can see that they've had incremental improvement in systemic therapy, but 2 years, their 2-year survival is kind of living in the 20 to 30% range. If you look at the outcomes of all the series with chemoembolization, at every time point, we're doing better. So based on kind of historical data, it seems like embolotherapy adds value over systemic therapy alone. There's never been a randomized trial proving it. It'd be very difficult to do, not impossible. But I think there's pretty good evidence that we add value in patients with liver-dominant disease, and you can take that to your medical oncologist. You're not taking the patients away. They can still give them chemotherapy. But what you want to be is you want to have a seat at the table at tumor board. You want to be part of the team. You want to show that you add value, that you can increase the chance of resection for cure, that you can provide better long-term survival than chemotherapy alone, and that you accomplish this by integrating yourself with the other oncologic specialists. So, thanks.
Okay. So thank you so much, Dr. Michael. Again, the same speaker, Dr. Michael, is going to talk about metastatic neuroendocrine tumors.
And the title of this talk is 25 Years in the Life of the Neuroendocrine Tumor. Why do I say that? Because the very first patient that I ever chemoembolized when I first came to Penn in 1991 was a neuroendocrine patient, and he lived 25 years. So this is a completely different patient population from patients with colorectal mets. And what people tend to think of is they think that carcinoid neuroendocrine tumors are incredibly rare because their incidence is low. But these people live forever, so the prevalence is high. So if you look at the prevalence of GI cancers, obviously number one is colorectal cancer. So in the US, over 1 million patients are out there with a diagnosis of colorectal cancer. But number two, by a large margin, is neuroendocrine, over 100,000 patients. No other GI cancer comes close to the prevalence of neuroendocrine tumors. So if you stay in one place long enough, your practice will be taken over by neuroendocrine patients. So in my clinic, the majority of patients I see every week have neuroendocrine tumor because they never die. So you keep getting HCC patients and colorectal patients, but in a year or two, they're dead. The neuroendocrine patients, they just keep coming back and coming back and coming back, and all your follow-up slots get filled up with neuroendocrine patients who you've been following for 5 or 10 or 15 years. So that's most of who I see now after 20 years is neuroendocrine patients. So there's a ton of them out there. No one understands this disease. They're desperate for help from someone who does. So if you can form a center, we have a separate tumor board just for neuroendocrine. And if you can provide a center of excellence with a group of specialists who understand neuroendocrine disease, all these people come flocking to you from all over because they're desperate for help and they cannot find doctors who understand how to take neuroendocrine tumors in the community. So again, start with a typical patient. This is a guy who walks into my clinic. He shows up with liver metastases only, no known primary, biopsy proven to be neuroendocrine tumor. He has no symptoms, performance status is 0. His liver function is completely normal, all his labs are normal. You have his MR, which shows a dominant lesion in segment 4, but scattered small mets really all through his liver. he gets an Octria scan, nuclear medicine scan, again, same thing, dominant lesion here, multiple lesions left and right lobe, no disease outside his liver, no known primary. So what else do you want to know? Well, in 2010, the World Health Organization changed the whole classification for staging of neuroendocrine tumors. And they did that based on differentiation and grading based on proliferation rate on histology. So what you really want to know is, have they had a core biopsy, and when you want to know the differentiation of the tumor, and you want to know either the number of mitoses per 10 high-powered fields or the Ki-67, which is an immunohistochemical stain for proliferation. And that's how you grade it. So grade 1, low-grade tumors are well-differentiated. They have 0 or 1 mitoses per 10 high-powered field and a Ki-67 staining of 2% or less. And then here's the criteria for intermediate grade, G2, and then poorly differentiated tumors with high proliferation rates are grade 3. And you want to know this information because it's very important for prognosis, and it also affects triage to therapy. And then we usually look for hormonal markers of tumor activity. So chromogranin A is a basic serum marker that's common to almost all neuroendocrine tumors. Some people look at serotonin. Some people collect 24-hour urine 5-HAA for serotonin metabolites. And then if they have a pancreatic islet cell tumor, that may make something very specific. It could make gastrin, insulin, whatever. So you may be looking at a specific hormone related to that patient's tumor. So that's kind of things we want to know starting out. And then the question is, what do you do with a guy? You have this patient who's completely asymptomatic. He has normal liver function. He has assuming he has a low-grade tumor, it's going to grow very slowly. He's basically living a normal life, and you cannot make him better than that. You sure can make him worse if you had a complication, but you can't make him better than normal. So do you just watch him? Do you put him on sandostatin? Do you send him for aggressive surgical debulking? Do you try to ablate all these guys, or do you embolize them? And the answer is you send him to a surgeon, right? Because this is the one disease where non-curative surgery improves survival. Like if you couldn't do a R0 resection for HCC or colon cancer, you wouldn't do it. Neuroendocrine, you can do a R1 resection and you will improve survival, statistically speaking. So you want a surgeon to look at this and say, could I go in there and just wedge and chop? I'll cut off the left lobe with the big guy, and I'll go for all those lesions on the right, and I'll either wedge or ablate every single one of them. And their surgeons will do 25, 30 lesions from neuroendocrine tumor to try to just get rid of all the tumor they can see macroscopically in the liver. Right? And that basically takes your 5-year survival from 30% to over 70%, even non-curatively, compared to patients who have the same tumor burden and don't get surgery. So we always have our surgeon look at these patients and say, it's worth a shot, or no, this is too crazy, has way too much disease. Should you put them on sandostatin? Should everyone go on sandostatin? Should only symptomatic patients go on sandostatin? So only patients who are avid for octreotide on their O scan get sandostatin? Or do you hold off for patients who have progression or have a high proliferative index? So the answer really is based on the PROMID study, which was done in France, where they randomized patients who had progressive disease, so known to have progression already, and they got randomized to monthly octreotide versus a monthly placebo injection. And their time to progression went up from 6 months to 14 months, doubled the rate of stable disease at 6 months, and it didn't matter whether the tumor was hormonal active or not. It didn't matter what the chromogranin level was. So based on this, the recommendations are that if you have progressive disease in the absence of any symptoms, everyone goes on sandostatin. But if they don't have progressive disease, you can just sit tight. And that's the graph from the PROMID study just showing the improved time to event rate in the octreotide arm versus the placebo arm. All right, so that's all we have to do for this guy, is basically say, we're going to scan you every 3 months, and if you progress, we're going to put you on sandostatin. And then we're going to keep scanning you every 3 months. And if you're stable at a year, we'll go to every 4 months. And if you're stable at 2 years, we'll go to every 6 months. And I have patients I've followed in my clinic for over 5 years, and I've never treated them because they show up with metastatic neuroendocrine tumor, you put them on sandostatin, and they never progress in 5 years. And that's all they need. But what often will happen is you'll find the primary. So you'll find this guy along, and the liver's stable, but eventually that mystery primary in the pancreas or in the bowel somewhere shows up on a CAT scan. So now what do you do? If someone has a primary that shows up and you know it's already metastatic and they're still asymptomatic, do you take it out or don't you? And so if this is colon cancer, you wouldn't take it out. Right? An asymptomatic colon primary is already metastasized, you don't do a colectomy. But for neuroendocrine patients, you do. All right? So if you remove a bowel primary, because the problem is that carcinoid tumors cause local problems. When they rise in the bowel, they call mesenteric fibrosis, and what you get is either bowel obstruction or ischemia and perforation. So they will get long-term downstream complications from leaving the tumor in place. And if you look historically at patients who get their primary out, even after it's metastasized, their median survival goes from 4 years to 8 years by resecting the primary. So for bowel primaries, we always take them out. For pancreas primaries, it's a much trickier question because you rarely have local complications from a pancreas primary, and operating on the pancreas is much riskier than operating on bowel. So the risk-benefit ratio is completely different. So those, we kind of talk to the surgeon, and usually if it's a distal tail lesion, they can do a distal pancreatectomy, splenectomy, which is a pretty safe operation. They'll do it. But if it's head or body of pancreas and they would need a Whipple, they won't do it because they feel the risk of a Whipple surgery is not justified by removing the primary because the primaries are hurting the patient other than being a source of metastases in the future. So as it turns out, this particular patient I'm showing you, his primary did show up after between 1 and 2 years, and he refused surgery. He was completely averse to surgery. He didn't want it out. And 2 years later, he perforated his bowel and had to have an emergency surgery. So he wouldn't listen, though. Okay, so now you're following the guy along, and finally, his liver disease progresses on sandostatin. So now what do? Do you increase the sandostatin dose? Now you operate on them, we ablate them, we embolize them, or use some systemic therapy. So this is where things get controversial. So why would you embolize or start some sort of liver therapy for neuroendocrine hepatic metastases? Well, one clear-cut indication is symptoms. So if they have symptoms from their disease, let's say diarrhea and flushing for carcinoid, and you put them on sandostatin and it doesn't control it, you have to embolize them because that will control their symptoms. If it's trying to affect their liver function, so the LFTs are not normal, you embolize them because you don't want them to go into liver failure. If their LFTs are normal, but the tumor's just growing to the point where you're nervous. So in the old days, I used to let them grow to 50% of their liver being occupied by tumor as long as their LFTs were normal. But then I got burned on a few patients who went into liver failure when I treated them. So now I've sort of shifted that down, so 25%. Once they hit 25%, I say, okay, it's time to treat you prophylactically so you don't get in trouble. The other reason I'll treat somebody is to make them resectable. So if my surgeon says, I need you to do this so I can then resect them, that's a good reason to do it. And then the question is, if they have less than 25% tumor burden, but it's growing, should you embolize now or should you wait? And there's not a clear-cut answer. My philosophy has always been very conservative, which is that I can only embolize you so many times in your life. And you'll need this for the rest of your life. And you will progress someday. So neuroendocrine patients, I've embolized some 16 times. I know people have been embolized 25 times. But at some point, the arteries get so pruned you can't go back. And the tumor will come back. So I tend to sort of string this out as long as I can between cycles of embolization so that 15 years from now, if they need it, I can still do it. Other centers, like Memorial Sloan Kettering in New York or Gustave Roussy in Paris, where Thierry Debert is, their criteria is any progression. If you have, I don't care if 5% of your liver is tumor. If you have 2 scan showing progression, we embolize you. It's sort of the surgical philosophy, which is early debulking, puts you in a better place 10 years from now. So I don't know which one of those is right, but both those philosophies exist. And then if you decide to embolize them, how are you going to do it? Bland, chemoembolization, yttrium, and are you going to add systemic therapy or not? So this is the same conversation we have for HCC and colorectal. Is one better than the other? And although in general I would say they're all about the same, this is one disease where I think that's not true. So some people will argue that you should do bland embolization because it works great. I mean, in neuroendocrine, everything works great, right? 90% response rate no matter how you embolize them. And people say, well, chemoembolization, you're just adding toxicity and you're not adding benefit. But that's not true. Right? So the toxicity from embolotherapy is from the embolization. The side effects, the symptoms come from ischemia, not the drugs. So if you look at patients who get chemoembolization versus bland embolization, there's no difference in morbidity, there's no difference in mortality, there's no difference in length of hospital stay. So forget that argument. There's no toxicity is not an argument for this. However, if you look at outcome, even though the response rate is extremely high, better than 90%, no matter how you embolize, in our experience, the durability of chemoembolization was much better than bland embolization. So if you look at time to progression, the blue line is patients who got bland embolization, 100% progression at 12 months. Whereas the chemoembolization patients, half the patients hadn't progressed at 2 years, and a third hadn't progressed at 3 years. So this is the only disease where I've seen this, where chemoembolization seems to provide a much more durable disease control than bland embolization does, even though the immediate response rate is about the same. So here's this is the guy you hate to see, the one who shows up where most of his liver's tumor already. So this is very tricky because he doesn't have much reserve left. The liver functions can be deceptively normal in neuroendocrine tumors because the tumors grow so slowly. So you can see patients like this who LFTs will be pretty close to normal. but they have almost no liver left. And you embolize them, and if they're lucky enough to survive, they don't go into liver failure, then you get this great response, and now you're sort of back to square one where you can start managing them from a better state. Carcinoids in general tend to do a little bit better than islet cells. So this is survival from diagnosis, survival from metastases, survival from embolization. The green lines are the carcinoids. The red line is the islet cells. And just in terms of biology, you can see that they tend to do prognostically a little bit better. What doesn't matter is whether they're hormonally active or not. So the left curve is hormonally active versus hormonally inactive tumors. No difference in time to progression afterward. And also the question of extrahepatic disease. Again, remember, this is a liver-dominant disease, usually with neuroendocrine. Over 90% of patients with neuroendocrine tumors of the GI tract or pancreas will have liver metastases. And that tends to be where most of their disease is. So many of them will have some extrahepatic disease, but it's the liver that gets them. So you can see, again, not a huge difference, and a little bit of separation between no extrahepatic mets and extrahepatic mets, but basically the survival curves are pretty much the same. So you're going to treat them with some form of embolotherapy. We tend to offer, again, either chemoembolization or radioembolization because I think they work similarly well. And they're similarly safe, so there's no mitigating issues. They can start with whatever one they want and then see what happens. So you treat them, wherever you start with, and then at some point down the road they progress. So then what do? Do you repeat what you did first? Do you switch to the other one? Give them more sandostatin? Give them systemic therapies? So one of the questions that comes up often is, well, can you switch how you embolize, and does it matter what you do first? So re-embolization, as I said, works pretty well. There's a couple large series out there. This top one, again, from Andy Kennedy, was 148 patients. This is the reference. Again, pooled from multiple centers. They saw very high disease, 95% disease control rate. Median survival was over 5 years. This is the largest series out of Australia. Again, Bester's group, only 48 patients, about 70-75% disease control rate. The overall survival is only about 3 years, and people who responded much better than people who didn't respond. So again, it works well. People ask, well, first line versus second line. People say, well, gee, if you chemoembolize them first, you've pruned off the arteries. How will I get my Theraspheres and my Cerspheres in there? And that's not to worry about. If the tumor's growing, it has a blood supply, and you will get there. So this was abstract we had at WCO a couple years ago for one of my students. We looked at 12 patients who got chemoembolization first and progressed, and we gave them Cerspheres, 60% 5-year survival, median of 70 months. Just what we saw in patients who were getting it first line. This was in a follow-up paper where we looked at re-embolization as second-line therapy after patients who had progressed on chemoembolization. So we looked at patients who got first-line Y90, so 67 treatments in 45 patients, versus patients who got second-line Y90, having prior chemoembolization, 40 treatments in 22 patients. Technical success rate was 100% in both groups. Dose administration, over 90% of the dose went in 76% of the installations, both groups. So our ability to deliver Cerspheres was not affected by the fact that patients had chemoembolization previously. So you can really sequence this any way you want. The other thing you have to know about when you're managing neuroendocrine patients is you have to understand all the systemic options because this is a very complicated disease. They're going to get all these therapies over time, and you may be the person who's their primary person. You may be their primary cancer doctor for 10 or 15 years because you imagine with embolotherapy. But what happens is in the 1980s, all these patients died either of uncontrolled hormonal symptoms or liver failure. And then along came sandostatin embolotherapy, and now they don't die anymore. So what you do is you keep them from dying of liver failure. So they all develop dissemination eventually, 5, 10, 15 years. So then what do? So you need to know about the options. And there's basically two major classes of systemic therapy. So there's systemic radiotherapy, or PRRT, peptide receptor radiotherapy. And that's a very basic concept. You can do an octreotide scan where you're injecting the patient with a mildly radioactive octreotide, which sticks to the tumor, and you get a scan. Well, you can take that same octreotide-like compound and instead stick on indium or lutetium or Y90, and now you've made a nuclear therapy that's tissue-specific. It binds to the sandostatin receptors on the, or somatostatin receptors on the tumor cells, and it basically has a beta emitter on it, and you selectively radiate the tumors. That's commonly done in Europe, never got approved in the US. There's a clinical trial going on now, but a lot of my patients, when they reach late stage of disease, they basically fly over to Europe and they get treated there. And the disease control rate is very high, so it's good at getting disease stability, between 2/3 to 90%. Not a super high response rate, so you don't see a lot of regression on this, but you do get very good disease control. Time to progression, 30, 40 months. So you can buy your patient another few years of stability if they do well with PRRT. Also, even though we don't think of GI and pancreatic neuroendocrine tumors as being avid for MIBG. MIBG, is the nuclear agent that's used for PHIOs and paragangliomas and sort of the norepinephrine transmitting tumors. It turns out actually that over half of patients with carcinoid or islet cell tumors will actually take up MIBG. So we do a diagnostic MIBG scan on every patient. And if they are MIBG avid, then we can offer them I-131 MIBG therapy, just like we would for someone with metastatic pheochromocytoma. So that's another possibility in some of those patients. Systemic therapies, there are basically two groups of drugs. There's the biologic agents and then the cytotoxic chemotherapy agents. So the two biologic agents are everolimus or Afinitor and sunitinib or SUTEP. One's an mTOR inhibitor, one's a tyrosine kinase inhibitor. And they work on many cancers, renal cell, lymphoma, et cetera. It turns out that they are also cytostatic for pancreatic neuroendocrine tumors. So you don't see much response, but they are anti-proliferatives. So there were two studies published back-to-back in the New England Journal of Medicine in 2011, one with Afinitor and one with Sutent for pancreatic neuroendocrine tumors, basically showing that you took their median progression-free survival from 5 months to 11 months. Doesn't affect overall survival because that is a huge distant endpoint in these patients, but it is a way of getting disease stabilization for a certain period of time. There's a lot of side effects of these drugs. Patients tend not to like them, but I always tell my patients, look, either you get the side effect or you don't. You don't know until you try. Some patients are on these drugs for years if they tolerate them well, so it's worth a shot if they have progressive extrahepatic disease. They're very expensive. In the US, it's $4,000 or $5,000 a month for these pills. So that's a problem because these guys live forever, so it's a huge debt burden and sometimes insurance companies won't pay for it. Interestingly, the companies that make these two drugs also did studies in carcinoid, and even though they had a positive study in pancreatic islet cell tumors that got them approval, they didn't have a positive outcome enough to get FDA approval in the US for carcinoid. So what he discovered is if you take neuroendocrine tumors and you first expose them to Xeloda, capecitabine, for 10 days, and then you add the temozolomide, all of a sudden you get all the cell kill. Because basically, when they're on the Xeloda, they get depleted of thymidine, and the cells need thymidine in order to combat the effect of the temozolomide. That's all I know about how this works. I don't know anything more. But basically, the combination has like a 60% response rate in well-differentiated neuroendocrine tumors. And again, it's just oral. You take it, you take oral Xeloda for 14 days, and the last 5 days, you also take temozolomide. Again, variable toxicity. Some patients do great. Some patients have been on this for years. Others can't tolerate it. They get too many side effects. But unlike everolimus and Sutent, it's not cytostatic. It's actually cytotoxic. So you actually get obvious responses. Now, the other thing that's very interesting about this combination is that capecitabine, Xeloda, is a radiosensitizer. So it's very commonly used in association with radiation therapy in GI cancers. So what we've started as a new protocol at our place for the more aggressive, like the grade 2 neuroendocrine tumors that have extrahepatic disease, so they need systemic therapy, we actually do Cap-10 Y90. So they start their capecitabine, and in the middle of the 2-week cycle, we do a Therasphere treatment. And then if they need a second one, we do it on the next cycle as well. So now we're combining the radiation from the Y90 with the Xeloda, which they're on for a week before and a week after the administration. And then we've done maybe a dozen patients with grade 2 tumors, and it's amazing. I mean, it just works so well. We'll see if it really pans out. And it's totally tolerated. I mean, there's no additive toxicity from the two in combination. So again, an opportunity for us to integrate with our medical oncologists to do liver-directed therapy with systemic therapy in combination for these little bit more challenging, slightly more aggressive grades of tumor. So we'll see how that pans out. So this is a very complicated algorithm compared to the colorectal cancer, and I'll end on this, I know I'm over time. But basically, this is kind of how I think about patients with neuroendocrine liver metastases. And I think you guys are getting a handout or something with all these slides, I hope. So basically, no symptoms, not progressive, normal LFTs, low tumor burden. You scan them every 3 to 6 months, and that's all you need to do. But consider curative resection or ablation in everybody. If they have symptoms or progressive disease with normal liver function and low burden, you put them on sandostatin. And if they stop progressing, you just observe them. If they're controlled, they have no symptoms, the tumor stops progressing, they go in the back of the stability arm and you watch them. If they have abnormal LFTs or a higher than 25% liver volume, even with normal LFTs, then we do liver-directed therapy. If they progress on sandostatin and get symptoms of tumor regression, they get liver-directed therapy. And then the ones who have extensive symptomatic extrapack disease get systemic therapy. And then where you integrate these two is something you discuss at tumor board with your colleagues. And that's it. Thank you.
Thank you very much.